will be with you. So good morning, everyone. I'm really excited about today's grand rounds, and I'm sure you too. I mean, dementia, we all have a family member with memory loss. I do. My father does have Alzheimer's disease. And I'm sure everybody knows someone or has a family member with dementia, because 1 in 9 people over age 65 have Alzheimer's. And mostly these are women, but some are men. But dementia incidence is increasing across the global. And I'm so excited about our speaker today. Dr. Cai is the director of Grossman Center for Memory Care and Research. She was previously the director of Neurodegeneration and Translational Medicine program at Mount Sinai. So Dr. Cai is trained in New York. She's moving to Minnesota for job opportunities. She completed her postdoctoral fellowship in neuroscience at Rockefeller University. Her residency in neurology was at Yale. She did her residency at Yale, and after that, she became assistant professor for the Department of Neurology at Icahn School of Medicine at Mount Sinai. She's very accomplished. I think the less I say is more, probably because you want to listen to her. Her research is our future. She has worked in neurobiology with Nobel laureate Paul Greengard at the Rockefeller also. So a lot of papers, a lot of clinical work. She runs a memory care clinic. We are just so lucky to have her. She has one disclosure, but it's not pertinent to our talk. So enjoy the talk, and we'll save the questions for the end. Thank you, Dr. Cai, for being with us. Welcome to Minnesota.
Thank you. Good morning, everyone. Thank you for this opportunity. And today I would like to talk about some exciting progresses in the dementia field regarding biomarker development and then anti-amyloid antibody therapies. Just a few disclosure slides. I work as a consultant with C20 Therapeutics for AD preclinical drug development, but I'm not going to talk about that today. So here is a general overview of the outlines of today's talk. I want to talk about clinical trajectory, biomarker development, as well as the symptomatic versus disease-modifying therapies for Alzheimer's disease. So as you all know that dementia is a set of signs and symptoms, not a disease. It's characterized by memory loss, changes in mood, and communication difficulties. Alzheimer's disease, or AD abbreviation, is the most common type of disease with dementia symptoms, followed by vascular dementia, Lewy body dementia, frontotemporal dementia, and others like traumatic brain injury. Since AD is the most common cause of dementia, so I want to focus my talk today with AD, but some of the points may apply to other pathologies as well. So Alzheimer's disease is the most a major healthcare burden with a large patient population. It's estimated about 6.7 million Americans are living with Alzheimer's disease, and about 37 million around the world. In 2021, the estimated cost for taking care of patients with AD and other dementia was about $355 billion. And these costs are predicted to be more than $1.1 trillion by 2050. There is a large unmet need to develop early diagnosis, prevention, and effective therapies for AD. Here shows two major neuropathological features of Alzheimer's disease. On the left side panels shows extracellular amyloid plaques due to excessive accumulation of A-beta, particularly the toxic form of amyloid species. The bottom one shows the neurofibrillary tangles due to aggregation of hypophosphorylated tau. The accumulation of toxic amyloid and the tau species lead to neurodegeneration and cortical volume loss with ventricle enlargement, shown in the right side slide. In the past 20 years or so, the central dogma in the field is the amyloid hypothesis, as summarized here, with the accumulation of amyloid leading to synaptic dysfunction, glia activation, tangle formation, followed by neuronal death. Subsequently, patient manifested with cognitive decline. On the other hand, increasing evidence suggests that AD pathogenesis is heterogeneous, with multiple factors contributing to the development and the progression of the disease, such as cerebrovascular risk factors, environmental factors, aging, genetic components, as well as brain and cognitive reserve. The complexity of AD is also supported by genetic studies. AD has a very strong genetic basis. The lifetime risk for developing dementia in general population is about 10%, but for family members of dementia patients, the risks are doubled. About 5% of AD population is comprised of familial AD patients with autosomal dominant mutations in 3 major genes involved in A-beta production, APP, PS1, and PS2. However, the majority of AD patients actually present in the sporadic late onset manners. In the past decade or so, modern genetic tools such as genome-wide association and whole genome sequencing technologies, as well as rigorous data mining approaches, revolutionized our field and lead to identification of many novel putative genetic variants for AD, opening new directions for understanding the disease mechanisms. I want to bring your attention to one of the strong risk factors of sporadic AD, ApoE4. In general, ApoE4 carriers present with increased risk of developing AD by 2 to 10-fold, and the time of onset with symptoms is much earlier than non-ApoE4 carrier. Recent data from clinical trial study also suggest that therapeutic responses and the side effect profile of ApoE carriers are different from those of non-ApoE4 carriers. We'll come back to that later. So showing this slide, we usually use 5 A's to summarize clinical manifestation of AD, including amnesia, aphasia, anomia, apraxia, and agnosia. Some patients have behavior symptoms such as agitation and mood swings. The disease progression is slow and insidious, with a gradual loss of ability to perform activities of daily living, as shown in this slide. Clinically, we arbitrarily divide AD into mild, moderate to severe stages. Prior to progression into AD, there is a mild cognitive impairment stage, an abbreviation we call MCI. This is a condition in which patients with subjective complaints of memory, language, or another cognitive function like executive functions, but not severe enough to interfere with daily life. Sometimes cognitive impairment at MCI stage can be picked up by neuropsychological testing. The data suggests that there is an increased risk of developing into AD in MCI patients over the next few years, particularly those amnestic MCI subjects with major complaints of memory deficit. However, not every single MCI subject will go on to develop AD. Now, we also know that years before any cognitive complaints of MCI or AD symptoms, there have been pathological changes in the brain, what we call the preclinical stage of AD. The evidence suggests that at preclinical stage, AD pathological changes such as amyloid accumulation in the brain can be detected 20 to 30 years or so before any clinical manifestation. In 2018, the NIA and Alzheimer's Association developed a research framework to incorporate biomarker changes into AD diagnosis. So the biomarkers are grouped into those of amyloid, A-beta deposition, pathological tau, and neurodegeneration, the ATN criteria. Basically, there are 8 different biomarker profiles defines three general biomarker categories: those with normal AD biomarkers, and those with non-AD pathological changes, as well as those that in the AD continuum. And the right side panel shows an example of a cognitively unimpaired subject with amyloid PET positive, tau PET negative, and MRI showing no evidence of atrophy, considered as a biomarker profile of A positive, T negative, N negative within the AD continuum. Then in this slide, you can see that the left side panel shows a proposed biomarker trajectory in AD continuum. And on the right side actually is a very nice summary showing ongoing biomarker development in the field with the effort to reflect brain cell type specific pathology in AD brains. Besides the well-established biomarker, as we discussed earlier, such as amyloid and tau, and there are other biomarkers on the horizon, such as changes in CSF and plasma NFL as indicators of axon degeneration, and CSF neurogranulin, as well as SV2A PET scan as a leading marker for synaptic degeneration. And there's also well-established astrocyte biomarker like CSF YKL40, as well as recent data showing the plasma GFAT as an indicator of astrocyte degeneration. The best characterized biomarker for microglia so far is the soluble TREM2 levels in CSF, as well as the TSPO PET scan for neuroinflammation. It would be interesting to know how these newly developed biomarkers integrate into the AD continuum along with the disease trajectory. Here's an overview of different diagnostic modalities and tests that can be used to measure various ATM biomarkers. We usually categorize them into imaging versus fluid-based biomarker tools. Each modality presented summarizing this table some of the advantages as well as the limitation in capturing the spatial temporal progression of AD versus affordability, accessibility, and scalability. For example, the PET scan ligand like amyloid and tau allows visualization and quantification of the spatial distribution of amyloid and tau pathology, but they only provide information on a single type of pathology at once. And also because the cost and the infrastructure requirements are quite high, which limit their utility. Fluid-based biomarkers are much more cost-effective and scalable, but they don't have information about spatial distribution of the pathology. For CSF, because of the invasiveness of LP, it's often caused a limitation. Recently, the blood-based biomarker have developed rapidly, showing a tremendous promise in ability to detect multiple markers at a more affordable, accessible, and scalable manners, particularly to those underserved and rural patient populations. This year's AAIC conference actually discussed about draft proposal with new diagnostic criteria to incorporate blood-based biomarker into the NIA-AA diagnostic framework. So in the next couple of slides, I want to discuss some of this current state of blood-based biomarker in AD. So in the recent couple of years, various reliable method and ultra-sensitive technologies such as mass spec and ultra-sensitive immune assays have been optimized to precisely and robustly quantify blood-based biomarker. And the left side panel shows that the detection of changes in plasma A-beta 40 to over 40 ratio could potentially help increase the confidence of clinicians in diagnosing AD from initially 60% to 85% or greater. The right side panel shows the changes in plasma P tau 217, in addition to other measures such as neurocyte testing and ApoE genotyping, can significantly improve the accuracy of predicting AD development among patients with cognitive complaints and MCI subjects. Here shows a couple of more examples. The left side panel shows the levels of serum NfL are mostly significantly elevated in converters from pre-symptomatic to symptomatic phase in familial AD mutation carriers. Moreover, the rate of NfL increase is highly predictive of cognitive decline in this subject. In a separate study using ADNI cohort, it has found that baseline NfL levels are much higher in MCI and AD subject than those in control. The right side panel shows data from a very recent study describing the presence of an astrocyte reactive biomarker, plasma GFAT, as I mentioned earlier, labeled as AST positive group, can predict a high likelihood of developing tau pathology compared to AST negative subject. So while we are very excited about the advancement in the field with blood-based biomarker development, it is important to be mindful that some of the biomarker described so far has not yet been extensively tested in broadly represented populations. Most of the data we have seen so far are from well-established retrospective or longitudinal cohort studies. Therefore, it is critical to know how blood-based biomarkers perform in a real-world patient population with heterogeneity. And then factors like age, sex, comorbidity, medications, lifestyles, or genetic variants that may affect the clinical interpretation of blood biomarker performance. For example, there are many studies suggest that concentration of NfL, GFAT, p-tau, or total tau in the blood may increase with age, while the plasma A-beta 40/42 decreases with age. In addition, there are also studies showing that individuals with higher BMI could have a lower concentration of plasma NfL. So it's laid out in this roadmap. I think a systematic assessment of blood-based biomarker is needed before we implement them into clinical practice. Now, once we have a highly validated blood-based biomarker, they will have that potential to be incorporated into our diagnostic framework to help streamline the process. As proposed in this slide, initial blood work in primary care setting for patients with cognitive complaints could highlight those who have higher risk progress into AD than fast track into receiving disease-modifying therapies. And for those with lower probability of progression, they could be referred to specialists to confirm a diagnosis using clinical assessment and gold standard imaging and CSF biomarker for diagnosis. And then for those with low risk, could then be evaluated for alternative diagnosis. So far, there are many blood-based biomarkers have been evaluated, and I think it's possible that we will need to develop a panel of different blood-based biomarkers with the best predictive value that might be the way to go. That being said, it is important to point out that while blood-based biomarker has potential to speed up the diagnosis, they cannot be developed and introduced into primary care in isolation and expect to make a huge impact. The clinical evaluation of patients still has very important role in diagnosing AD and other dementia. It would be very dangerous to think that we can move to diagnosis based on single biomarker result. I think down the road, the best practice to improve diagnosis using the blood-based biomarker would be increasing the physician education with a clear practice guideline on how to use and interpret results from blood-based biomarker tests, especially those that are involving a panel of biomarkers. Besides the clinical practice, there's also great promises using blood-based biomarker in clinical trial design. As proposed in this slide, in pre-screening steps, a diagnostic algorithm based on blood-based biomarker could identify cognitively normal individual as being at low risk or high risk of having preclinical AD. That in the screening steps, when those individuals deemed with higher risk will undergo further testing using either amyloid PET scan or CSF studies to confirm or rule out the presence of AD pathology. But this type of pre-screening really could result in a substantial time and cost saving with much fewer CSF and PET scan needed to identify the patient population. And then in the enrichment steps, a prognostic algorithm can be used based on the blood-based biomarker profile to identify the individuals that likely exhibit more severe disease trajectory and cognitive decline. So those patients can be included in the trial enriched for such individuals. And this kind of enrichment also enable a clinical trial design with a much shorter duration and fewer study participants. I can discuss some of these advantages using biomarker-guided clinical trial design in the later part. So let's talk about therapy. For a very long time, we only have symptomatic treatment for Alzheimer's disease. Here's a list of 5 FDA-approved oral medications. 4 of them are cholinesterase inhibitors, and 1 of them is NMDA receptor antagonist. All these medications do not stop or slow down the disease progression, and it only offers symptomatic relief. And the beneficial effect tends to plateau after 6 months of treatment. With a large unmet need, there have been a lot of effort in the field focusing on developing disease-modifying therapy. So here shows schematic summary or comparison of different antibodies directed against different aggregation state of amyloid. The first generation antibodies such as sulanimab or bapineuzumab tend to be directed against A-beta monomer that fail to show significant clinical efficacy, suggesting that maybe oligomers, protofibers, and plaques might be a better target than monomer. And then the second generation antibody like lecanemab and donanemab certainly has a higher preference into protofibers and plaques than monomer. And in this slide shows a summary table of clinical trial results of 4 second generation antibodies. And you can see that there are 2 positive results from clinical trial study with lecanemab and then donanemab. And then 2 conflicting results with aducanumab. 1 is positive and 1 shows no effect. And then gantenerumab has 2 negative results. Next, I want to focus on the clinical trial result of aducanumab, lecanemab, donanemab, given that these are the 3 major IV infusion antibody therapies, while gantenerumab is delivered through subcutaneously, and the unexpected value may require some other time to talk about. So aducanumab is a monoclonal antibody targeted at A-beta, either monomer and plaques. The table 1 shows the summary of patient demographic in 2 clinical trials, ENGAGE and EMERGE. The participants were ranging from 50 to 80 years of age with a diagnosis of early AD, and they need to be positive for amyloid pathology PET scan. At the baseline, the mini-mental score is ranging from 24 to 30, and the CDR sum box of 0.5. And in both studies, you can see that ApoE4 carrier is ranging between 60 to 70%. And in these 2 studies, the participants were randomized 1:1:1 to low dose, high dose versus placebo. And the randomization also stratified based on ApoE4 carrier status. You can see that there are 2 dosing protocol with additional amendment in the mid-study when they increased the higher dosage for ApoE4 carrier into 10 mg per kilo. And here's just to show the clinical outcome measures of 2 trials with 301 or ENGAGE shows no statistically significant improvement in either low dose or high dose treatment group, while 302 in the higher dosage actually shows quite statistically significant slowing, with about 22% of slowing disease progression with primary outcome measure CDR sum box. And on the other hand, the biomarker measures show that the drug can effectively remove its target in a dose-dependent manner. And then top panel shows the amyloid PET studies, and the bottom one shows the measurement of p-tau 181 levels. Again, the aducanumab treatment leads to statistically significant reduction in both trials. One important lesson we learned from aducanumab clinical trial is that this is not benign. There have been significant adverse side effects reported among patients treated with aducanumab that require close monitoring. Here shows some imaging example of ARIA, stand for amyloid-related imaging abnormalities. Now, ARIA-E refers to this parenchymal edema that picked up in FLAIR imaging of MRI studies. And then ARIA-H, in this particular case, a microhemorrhage picked up in the gradient echo. And this table shows overall about 2 to 4-fold increase in developing ARIA with aducanumab treatment group. And if you are ApoE4 carrier, this incident increased by 15 to 20-fold. Because of this lack of evidence showing a consistent clinical benefit, there have been a lot of controversies over the FDA approval of aducanumab. But I want to point out the funding from aducanumab trials did help us better prepare for next treatment down the line, such as the increased awareness of side effect profile, the infrastructure needed to support this type of treatment, and the importance of ApoE genotyping in AD clinical trial design, outcome measures, and side effect monitoring. Now let's talk about lecanemab, the rising star of anti-amyloid antibody therapies. So this is actually a monoclonal antibody selectively binds to soluble A-beta aggregate species with a much higher affinity to protofibers, oligomers over monomers and fibers. The right side panel shows the phase 2 and phase 3 clinical trial design. Based on the phase 2 dose-finding clinical trial result, Clarity AD phase 3 clinical trial was designed to carry a 18-month double-blind placebo-controlled involving subject with early AD, and the participant would receive either IV lecanemab infusion at 10 mg per kilo every 2 weeks without any titration, or placebo, really based on the result they got from phase 2 clinical trial. And the randomization was further stratified based on clinical subgroup, such as there are MCI due to AD or early AD, as well as the ApoE carrier status. Here shows the result. The primary efficacy endpoint was the changes in the score of CDR sum of box from the baseline. As you can see, by 18 months of treatment with lecanemab, there are about 27% of slowing in disease progression. What does that mean? What does that translate into clinical meaningfulness? So the slope analysis based on the trial result suggests that if you project the lecanemab treated groups, they take them about 25.5 months to reach the same level as the placebo achieved at 18 months of time, suggesting this drug is slowing down the rate of the disease progression with an extended duration at MCI and mild AD stage. So then the subgroup analysis also performed with lecanemab trial studies, again showing quite consistent beneficial effect in various subgroups. And very interesting trend noted, such as like mild AD seems to have a more favorable outcome than MCI subgroup, and certainly ApoE4 non-carrier has a more favorable outcome than the ApoE4 carrier. They also noticed some sex differences in response to lecanemab, as well as differences in different race and ethnic groups. It'll be interesting to know the data from real-world practice with lecanemab infusion treatment, and then whether this kind of data can be replicated in real-world population. Lecanemab also showing drastic reduction of amyloid plaque as measured by amyloid PET scan at all time points. And again, measuring the p-tau levels in plasma certainly shows drastic reduction with lecanemab treatment, suggesting a downstream effect of lecanemab on the tau pathology. There are some reported deaths in participants of lecanemab treatment versus placebo control. However, none of those deaths considered to be related to lecanemab-induced infusion responses or ARIA. Then this is the table to show the breakdown of different adverse side effects seen in lecanemab treatment versus placebo. There's much higher rate with the infusion-related reaction, as well as the ARIA-E and the ARIA-H. And you can see that certainly the infusion-related reaction in the lecanemab-treated groups tend to be usually mild to moderate if you grade them from 1 to 4, with grade 1 and 2 are really just very mild discomfort, tend to be not disrupting the normal daily activity. And most of the subjects that reported with infusion-related reaction tend to happen to the first infusion. And then 6 out of that 7 severe infusion also occurred during the first dose. And then the ARIA-E incident with lecanemab treatment are generally more commonly seen with ApoE4 carrier than non-ApoE4 carrier. And seems the ARIA-E tend to happen within the first 3 months of treatment and plateaued by 6 months. And then most of the ARIA tend to resolve within 4 months of detection, regardless their ApoE4 carrier status. The most common reported symptoms related to ARIA-E were headache, visual disturbances, and confusion. Now here, just to show the breakdown of ARIA-H incident rate. In general, the isolated ARIA-H are similar between lecanemab treatment and placebo group, with relatively low rate of significant symptomatic ARIA-H. The most common symptom associated with isolated symptomatic ARIA-H was dizziness. And then the timing for ARIA-H development usually occurred quite randomly, could be any time point during the treatment course. But however, the ARIA-H that occurred along with ARIA-E tend to occur a little bit earlier in the course of treatment. Again, we see a much higher incident rate in ApoE4 carrier with lecanemab treatment than the non-ApoE4 carrier. So then, since the approval by FDA, there have been a lot of recommendations and guidelines implemented or suggested to help guide the use of lecanemab into clinical practice. It is recommended that all patients being considered for lecanemab therapy should meet the diagnostic criteria for MCI due to AD or mild AD dementia, with biomarker evidence either using PET scan or CSF to confirm the AD pathology. And because that lecanemab phase 2 and phase 3 trial excluded patients outside of a specific age range, as well as the body BMI, so then it is actually up to the prescribing physician's judgment when it comes to patients that come out of the age range or at the extreme of the BMI cutoff. However, patients with cognitive enhancing agent like cholinesterase inhibitors or mementin or standard care for medical illnesses should not be excluded for consideration unless they're on different antibody therapies such as aducanumab or anticoagulation therapy. Here shows a couple of exclusion criteria for consideration, such as non-AD dementia, history of intracranial hemorrhage, a recent history of stroke, TIA or seizure, major depression, patient with bleeding disorders, or on anticoagulation therapies is suggested to consider to be excluded for lecanemab. We always say that it takes a village to achieve best practice and patient care. Here comes a recommended infrastructure with resources needed for safe and effective use of lecanemab. I think the development of a protocol to manage severe and serious side effect is very important at medical center and institution level to implement a treatment program like lecanemab. And here are some examples of recommended protocols for monitoring and managing ARIA when it comes to lecanemab treatment, such as suggested MRI interval for scanning, as well as the ARIA management protocol to manage the range of symptoms that might occur. So besides the positive results from lecanemab, the recent clinical trial result from another anti-amyloid antibody therapy, donanemab, is also very encouraging. The unique aspect of that trial was the inclusion of tau pathology assessment during clinical participant enrollment stage. Basically, the trial included participants that aged between 60 to 80 with MCI due to AD or early AD, with amyloid pathology confirmed by PET scan. In addition, they want to confirm the presence of tau pathology by tau imaging studies. Then they categorize their study participants based on tau scan into the low, medium versus high tau burden. Afterwards, then they randomize the participant receive either donanemab IV infusion every 4 weeks up to 76 weeks or placebo. Here are the results. The primary outcome they use actually is an ADAS score from the baseline. However, to compare with all the other clinical trial I mentioned today, I put the CDR sum box result here. You can see that in low or medium tau population, the differences between donanemab treatment versus placebo was about 36% of slowing in clinical progression. And then in combined group, basically there's about 28.9% slowing in clinical progression. This slide shows the breakdown of all the adverse side effects noted, and there are 3 deaths reported with donanemab treatment related to induced ARIA. And then the incidence of ARIA-E and ARIA-H lumped together is about 36% with patient received donanemab versus 15% received placebo. Then the infusion-related reaction were reported about 8% in patient received donanemab versus 0.5% in placebo. Most of those reactions were similar to others, like very mild to moderate, and tends to occur within the early infusion period. So to put them together, I think overall the clinical trial result of anti-amyloid antibody therapies do support the amyloid hypothesis and then amyloid as a target for AD drug development. While we observe some of the differences in different clinical trial results, I think the most promising result from the most recent 2 clinical trials highlight the importance of using AD biomarker for patient selections in clinical trial design. On the other hand, we should be mindful about the ceiling effect of anti-amyloid antibody therapies. As the most effective treatment regimen, the best clinical trial design we see so far, the effect size we have observed is really only around 30% of slowing. That suggests probably there are other pathways and targets other than amyloid contribute to AD pathogenesis. As summarized in this model, it is increasingly recognized that AD is a multifaceted disease mechanism with multiple processes involved, such as endolysosome pathway, lipid metabolism, and neuroinflammation. So current paradigm for AD drug development has been shifted towards therapy target different various disease mechanisms, either through single agent or combinational therapy. And then with the concern over the safety profile and the cost effectiveness of antibody infusion therapy, oral bioavailable small molecules are urgently needed. So this slide shows the current landscape of AD drug development pipelines, with the majority of the effort on disease-modifying therapies. There are about 36 agents at phase 3 clinical trial at the moment, and many at a phase 2 clinical trial. As you can see, they target on many disease pathways other than amyloid and tau. About 8 of them are expected to impact AD pathology in multiple mechanisms of action. Besides pharmacological approaches, the benefit of non-pharmacological intervention should not be undermined. A meta-analysis study estimated about 35% of dementia cases attributable to non-modifiable risk factors across the lifespan. By modifying some of these risk factors with non-pharmacological intervention like exercise, diet, and cognitive training could significantly reduce the risk of developing dementia. So then I want to summarize my talk today. Alzheimer's disease is a complex disorder with multifaceted disease mechanism. A result from recent clinical trial study of anti-amyloid antibody therapy hold promises for amyloid-targeted therapy. However, the high cost, significant side effect profile, and infrastructure requirement for antibody therapy support the urgent needs of developing bioavailable oral small molecules for disease-modifying therapies. And the success in biomarker-directed clinical trial design highlights the importance of future precision medicine-guided, biomarker-based early diagnosis and preclinical trial development. I'll stop here. Thank you very much.
Thank you. Thank you, Dr. Cai. Got to know a lot of new things that we weren't aware of, but I have lots of questions. And I see Dr. Banish is also in audience. So between the two of you, I think we'll probably get some clinical answers here. Your research is our future, but we have a lot of clinical questions for you. Number one, a lot of facilities are doing spinal taps for patients who are suspected to have Alzheimer's disease. What is checked in the spinal fluid and what biomarkers help you in the spinal fluid to determine this is Alzheimer's or other dementia?
Yeah, so there are CSF panels available for diagnosis of AD. Most well-established, including the A-beta 40, 42, p-tau, total tau levels are all being, studied and well-established in the field for indicating a high likelihood of AD changes. There are a few other new biomarkers have been also evaluated, as I discussed before, but they're still in the really early stage. But I think the four that I listed so far are quite well established, can be used.
Great, thank you. So does everybody need a spinal tap? When do you do the spinal tap?
So not everybody needs a spinal tap. When we have, usually the clinical presentation is quite supportive of the diagnosis. We tend to not use that. A lot of times we actually use that for rule out. When we think it's a typical Alzheimer's. But then nowadays, the CSF study also have a major importance when come to clinical trials, certainly that for research purposes, not necessarily for clinical practice per se. But CSF biomarker, when come to clinical trial, it's important to confirm the AD pathology before we enroll them into trial design specific for AD treatment. That being said, clinical practice-wise, a lot of times CSF biomarker study used when we have a high likelihood or concerns, and that may be a typical clinical presentation.
Great. Thank you. So there's another question about biomarkers in the chat. Sorry, your name didn't come through like in the texts that I'm getting. So the person has written there, do you think that screening for biomarkers in some form will be a part of well-being and preventive medicine visits in future to help find people who become symptomatic later on?
Yes. Answer is yes. Brief answer is yes. But certainly we have a long way to go. We're not there yet. I do think that blood-based biomarkers hold a lot of promises in that. And I do think that current studies in the field is quite encouraging in the sense of implementing that blood-based biomarker into the primary care settings. But they need a lot of work on validating in the real world populations I mentioned earlier. So right now, all this biomarker data, particularly like p-tau, showing quite promising result with plasma p-tau changes. And there may be still some debate about which epitope would be the best to go for, like p-tau 181 versus p-tau 217. But overall, the p-tau data looks quite promising. They are very sensitive in detecting pre-symptomatic stage patient, have a high predictive value about the patient developing to MCI and later on early AD. But that being said, all these studies really carried on, as I said, in a very controlled, retrospective, longitudinal cohort. We really need to know how they perform in real world population with all the heterogeneity taken into account. So once that's being confirmed or validated, it can be implemented into the framework for diagnosis and speed up the diagnosis for primary care. That's the hope.
Thank you. So next 3 questions that I've received are about treatments. So amyloid treatments obviously are very exciting. And patients are beginning to ask us about amyloid treatments. How do you do the patient selection?
For amyloid treatment, patient selection, I think I lay out some of that in the talk already, in a sense, but certainly there is a few, usually, it is indicated for mostly, MCI due to AD, and then the early AD. So there is a recommended range for mini-mental score, from certain range, 22 to 30, if I recall, for lecanemab. For donanemab is, I believe, is 20 to 28. Different antibody treatment might be slightly different. But that being said, there's also consideration, make sure this is, high likelihood, this is due to AD, and then we need to confirm the amyloid pathology, either use PET scan or CSF study. So that's where CSF A-beta study would be handy for confirming the lecanemab treatment criteria eligibility. Then there's a lot of discussion about rule in and rule out, right? We have to exclude some particular histories, medical conditions, illnesses, as I discussed. So the discussion, the eligibility consideration is a long discussion. We might need to go through that and develop a good guideline for our community to follow up with.
Thank you. So some other questions about the treatment. So what does that do to the acetylcholine treatments is one first question. Do we start the same way with acetylcholine receptor treatments as previously? Number 2, how long should Aricept or Exelon or those medications be continued as dementia advances?
So this is talking about the symptomatic treatment cholesterol inhibitor, so yeah, so currently the practice usually is recommended for cholesterol inhibitors for mild AD, mild to moderate AD stage. In general practice, there's no particular specific guideline in the way for how long. Depends on the patient's tolerability in general. If they are, I tend to practice is start slow and start low. And then once patient adapt to develop the tolerability with minimal side effect, I tend to titrate up and then maintain them unless there are any obvious side effect or tolerable problems, or then I usually maintain them on the cholesterol inhibitor. When the disease progresses into moderate stage, often we consider to add memantine, which is the MDA antagonist in addition. In that case, to help some of the patient. Not every patient will have benefit. We get maybe about 30% within my patient population may report some beneficial effect, but as I discussed, some of that effects tend to be plateaued after first a few months. So when I start to talk to patients, I often provide all this information as a discussion. There will be some patient may not have benefit. There will be patient, tend to plateau afterwards. They have the choice to decide go on to it or not, but certainly something to offer.
Another question about treatment is that for acetylcholinesterase inhibitors, the centrally acting acetylcholinesterase inhibitors like Aricept or donepezil, I should say, do you have a preference for which acetylcholinesterase inhibitor, or they are all similar in efficacy?
Yeah, I think it's. I don't think there is a lot of data suggesting one works better than the other. Just probably just more of a practice of habit. A lot of it seems like interesting to observe that at East Coast where I used to practice, we tend to use a lot of donepezil, but here I see much more variety. Ristectine is a good choice as well. I don't necessarily see major differences in response-wise, but patches wise, some patient may have GI symptoms that has tolerability. Then, alternatively, like a rivastigmine has patches that you can use that in some patients might be better to use. So overall, there's no major, data suggesting one superior than the other. But I do want to point out there is a very interesting publication in neurology a couple of years back then, showing that cholinesterase inhibitor actually could decrease the mortality of dementia patient overall in the long run after 20, 30 years of follow-up in the dementia patient. So in that sense, actually, is one of the very interesting studies suggesting maybe there's a component of disease modifying effect with cholinesterase inhibitor, other than just symptomatic relief. So very interesting observation.
Thank you. So Dr. Azutamiz, I hope I'm pronouncing the name correctly, has a couple of questions. Dr. Azutamiz, you are on speaker if you want to unmute.
Yes, can you hear me?
Yes.
So I'm a neuroradiologist. I haven't seen any single case of ARIA in our center. Do we administer these new drugs, or are they only applied for research? Thank you.
As far as I know, Sarah probably, I see that Sarah is here, may be able to comment better, but I think as far as I know, we have not yet providing lecanemab in our center, but we are working on a pipeline development. I think the plan was hoping to be able to offer lecanemab by 2024. And then the logistic steps, probably Sarah can comment better.
Yeah.
Go on.
Thanks, Dr. Cai. Hopefully you can hear me okay. So we, in true neurologist fashion, are taking a cautious, slow approach. And as Dr. Cai just outlined in her excellent presentation, I think there's reason to do that. While we all want to have effective treatments, there's a lot of logistical things we need to align up here, including access to MRI scans fairly frequently at the beginning of infusions, infusion center capacity, et cetera. So we're working towards a plan to launch infusions of lecanemab. I think it will launch spring of 2024. We will clearly communicate with all stakeholders before what the protocols are. I know we have very difficult access in neurology. We are building in some emergent access spots to help start the infusions, manage the complications. We're going to be meeting with Dr. Emily Olson from the geriatrics practice to make sure that we're working with our primary care and geriatric partners clearly. So we're getting essentially our ducks in a row. We'll warn you when it's coming, and we'll also be working with neuroradiology on hopefully getting some consistent reads of reports so everyone can understand if there are complications being seen. So more to come in 2024. Very hopeful for that time. Thank you.
And one final question: what's the price of these drugs?
Lecanemab is, I believe, $27,000 a year.
Okay,
Hence the
thanks.
reason why we're starting slowly, because we really want to make sure we're doing this right and that there's value there.
Okay, thanks.
Great. Thank you. Excellent questions. Couple of more questions. I hope that's okay, Dr. Cai, or Dr. Banish, whoever can answer. So a lot of testing, which is embedded in the annual preventive visits, finds these people when they're little more advanced. Is it a cognitive testing which we can apply to MCI patients so that they can be screened more rigorously?
Yeah, so certainly, you know, most of the patient, if we consider as eligible for lecanemab, I would recommend to have a full neuropsychological evaluation, get a clear picture about different domain of impairment, and that one thing could help us to understand the seminology of the dementia in general, and also to kind of categorize the patient, particular MCI stage. You know, are they amnestic MCI? Are they multi-domain? Are they more, you know, impaired in the executive function? So it depends on that. So I do recommend if the patient meets the criteria for consideration, to get a more thorough neuropsychological testing.
Great.
In that aspect.
Are there specific patients who need neuropsychological testing? Because I know that there was a neighborhood article just this week about more access to neuropsychological testing. But I mean, with the shortage and the access issues, are there certain patients that we select for neuropsych testing?
In the sense of for treatment, or in general, just practice-wise?
Screening and treatment.
Right, for cognitive impairment in general. So I mean, in the clinic, we do like to do some abbreviated cognitive testing as a screening, if that's something particular question relate to, such as, you know, MoCA is something we tend to use a lot. Did provide a reasonable sensitivity for pick up a specific screening domain, you know, a particular domain of impairment. SLUM is a good one to use as well. Mini-mental, some neurologists may use. I personally use less so. So MoCA and SLUM are the one that I tend to use more. Did provide a little bit more sensitivity in the sense of picking up cognitive impairment, particularly at the MCI stage. If I do find more reliable impairment, particularly like in memory aspect, or you know, other specific domains that are suggesting potential Alzheimer related process that could be eligible for lecanemab, then a thorough neuropsych testing certainly would be considered. And you know, if it's other component like you know, pseudo dementia, as we talk about, based on very extensive psychiatric components or some other medication related, sometimes this kind of we call bedside screening tool could separate or help differentiate in that sense.
Great. Thank you for these great questions. This is It makes the talk even more robust. Thank you. Dr. Cai, this was excellent. A lot of things that you talked about were news to most of us. So we hope to see you back, and thank you for joining the division. Hope to work with you in future.
Thank you for having me. Thank you. Take care. Bye-bye.
Okay, so audience, I will see you next week. And that's another exciting talk, a breakthrough for medical treatment of obesity. And with the new drugs on horizon, I think we will learn a lot. So I will see you next week. Have a great day. Thanks.